Avoid having to retreat your cases by really understanding relapse. My name is Hisham. I'm a specialist and consultant orthodontist. I teach orthodontics to specialty trainees and to general dentists, and I have a special interest in aligners. Relapse is a fundamental thing that you need to understand to ensure your cases are well retained and the teeth don't move back into the original positions. And that really is how we define relapse, which is relapse is the return following correction to some of the original features of the malocclusion. So that's what relapse actually is that the teeth want to go back towards their starting point once we're finished the treatment. There's a few different things which lead to relapse, so we'll talk about each one of those in order. So the first thing which causes relapse are the periodontal fibers. So the periodontal fibers are interconnecting between the teeth, either tooth to tooth, or they can go from tooth to the bone. And it is these supracrestal fibers, which are high up in the gingiva, which really lead to the long-term relapse. We need to hang on to the tooth positions for long enough to allow remodeling of all of the periodontal fibers, but they do remodel at different times. So the periodontal ligament fibers tend to remodel within 3 or 4 months. Some of the gingival fibers will be roughly 6 to 9 months, but it's the elastic supracrestal fibers which can take 12 months or even a little bit longer. And remember that it is the average which we're quoting here. So some patients might remodel a little bit slower and some might remodel a little bit faster, but it's unknown which of these your patients is going to fall into. So it's important that we do retain the teeth in that final position for as long as possible. The second factor which leads to relapse is occlusal factors. Improper or incomplete correction of the occlusion can lead to the teeth moving back. For example, if we don't really fully correct a crossbite, we might not have teeth which are well intercuspated, and this allows them to slip quite easily back into an inappropriate position. For example, a premolar which has been brought out of a buccal crossbite by simply tipping the teeth and does not have adequate root control, well, that can lead to the crown of the tooth swinging back in a palatal direction and re-establishing the crossbite. So not controlling the occlusion at the end and during the treatment can lead to relapse as well. And achieving good intercuspation in the buccal segments and a positive overjet and overbite at the end of treatment will help to improve relapse by contributing to good stability. The third factor which can lead to relapse or perceived relapse are age-related changes, and this is something which happens to everybody. It's not really truly relapse because it's just a result of maturational changes. We know that throughout our 30s, 40s, and 50s, the mandible tends to become a little bit shorter and a little bit narrower as well, and therefore there's less space for the teeth to sit in. And as these changes are happening, the tooth size isn't really changing, and as a result, we're getting an expression of crowding where there's less space available for teeth which are of the same size. So trying to avoid treatment which increases, the reliance on space by expanding the intermolar or intercanine width is a good idea. Try to avoid doing those kind of mechanics, and again, try to retain the teeth in the long term, even if it's for a few nights every week, so the patient isn't really experiencing as much age-related change as we might expect. The fourth factor to consider is soft tissue changes, and there's a variety of different things which might impact how the soft tissue can affect relapse. One of the key things really is stability. So have you as a clinician provided treatment which maintains the teeth in the equilibrium zone in that area of neutrality, or have you put the teeth into a position where the soft tissues are now going to start pushing on them with greater force and determination? So if you've proclined the teeth quite massively, then actually the lip is going to try to push them back very, very quickly. So your treatment is not stable, and the soft tissue influence is going to result in relapse. Other examples might include proclining the upper incisors and leaving the patient with a full or partial lip trap. That will have the effect of worsening the lower incisor position by retroclining them and proclining the upper incisors at the same time. So ensuring that your treatment doesn't leave the patient with unwanted soft tissue side effects is really important. Otherwise, you'll end up seeing quite negative changes in your patients as a result of that. So those are the four factors which really we need to consider when understanding relapse. The risk of relapse is never truly eliminated, and that's why it's up to you to discuss with your patient the need for long-term retention and consent them to wear retainers for as long as they really want their teeth to stay straight. And that's exactly how I explain things to my patients, that you are going to have long-term changes, which I can't really avoid, that there is a risk of further tooth movement as time goes on, that you do need to wear your retainers for as long as possible, and there is a cost involved in replacing your retainers, which will need to be routinely replaced every 2 or 3 years. So it's important that you understand the factors that are going to contribute to relapse in your case with your specific set of patients, and then understand and discuss with them the need to retain for as long as possible, as well as explaining to them what that is going to involve in each specific case. Thanks.